I'm going to just start with one question for you. Do you use tranexamic acid at all in your patients with thrombocytopenia and bleeding?
I am afraid of the word all, but I use it very often in most of the patients. I find it interesting. There are no clear-cut data, no clear-cut evidence, but from personal experience, yes, I usually use either tranexamic or hexacapron, especially in the patients who have relatively normal kidney function. Yes.
Okay, thank you. Dr. Cazzola will now field questions from the audience.
Okay, so first question is by Ari Yagunidis. If MDS patients are severely thrombocytopenic, below 30, and do show superficial bleeding on anticoagulation, not responding to thrombopoietic agents, do you add the tranexamic acid or do you rather interrupt anticoagulation?
My dear friend Ari, you are always asking the tough questions. Well, it's easy to start tranexamic or hexacapron, at least if the creatinine is okay. Whether to stop the anticoagulation, it's a tough question, which I think we should still consider on a patient basis, you know. So in some of them I do, in others I don't, in others partial dose. So, but yes, antifibrinolytic, definitely yes.
Now the question is, what's the percentage of patients in the DOAC trial that were on concurrent aspirin?
Well, unfortunately, I have to admit that I don't remember at the moment, but one has to take into consideration that there is really very few data, and all this data should be regarded with a grain of salt. So I would say aspirin can be used. The risk of bleeding, as I mentioned, is relatively higher than the risk of thrombosis. But in certain situations, such as acute MI, it may be recommended. I also use it in some of my patients with atrial fibrillation, despite the thrombocytopenia, such as the patient that I presented in the beginning of my talk.
Okay. Ioannis Kotsianidis is asking whether there are data regarding the potential effect of the thrombophilic profile of the patient. So let's say inherited thrombophilia on your therapeutic decisions.
Unfortunately, not that I know of. And actually, I reviewed the literature and didn't find really convincing evidence about this kind of subpopulations. Again, it will be interesting if eventually, as I hope, the embargo will be raised and we will be able to use again the thrombomimetic agents. They might induce thrombophilic situation, but which is more important than may increase the platelet count and may solve the problem.
Jason Mendler is asking if you use a thrombopag in lower risk MDS patients with thrombocytopenia.
Well, Dr. Mendler, as you may know, unfortunately, both agents, romiplostin and L-thrombopag, are not approved because of the suspicion that they may stimulate disease progression, as I mentioned. However, I think if we critically summarize the literature, which I was trying to do, the risk is mainly in the higher risk patients and less significant in the lower risk patients. So if I can, and I have to admit that some of my patients use L-thrombopag, especially if they have the borderline situation between ITP and MDS, and I believe that it is safe, but I have to be cautious. Currently, they are not approved, and I hope that in the future, we will have either these agents approved or new agents.
Shelby Rifkin would like to know about the use of factor 11 anticoagulation.
I don't have personal experience, and unfortunately, I am not familiar with data about it. Not yet.
Okay, so thank you very much again, Moshe.
My pleasure as usual, and hope to meet you face to face soon.